Good morning, everyone, and thank you for coming to this seminar. I'm very pleased to welcome Ludovico Carrino, who is a professor at the University of Trieste. Ludovico did his PhD in the University of Venice, where he started working in long-term care, and since then has become very much an expert in long-term care. We worked together in King's College London for many years. We've also published together. And I thought it would be really a nice occasion for someone who knows really long-term care and who will give us a little bit of a European perspective on this topic. So thank you very much for coming, and then I'll give you the second.
Thank you, Mauricio, for inviting me, and I'll keep track of time. I'm Ludovico. I worked with Mauricio. I don't know whether I'm an expert on long-term care, but thank you for saying that. I'm also an economist, so I will perhaps bring different perspectives and use words in a way that you don't like. Let me know, because I like to learn from multidisciplinary perspectives, actually. So what I'm going to present is an economics perspective. I'll be rather broad in order to cover many topics, but I'm happy to go in details if and when you want. First of all, some thanks to the partners, institutions that I have or am collaborating with, including Unisanté, of course, that basically are part of this study. And the results that you see are made by me together with other authors and friends from all these organizations, and some projects that are involved in this presentation, and that through the European Commission or through the ESRC have funded, and some Italian Ministry of Health also funded some of the research that I'll present today. I'm a public economist. I work at the University of Trieste. My research agenda is mostly on aging-related social protection policies, pension, social care, social benefits, health policies. I adopt a comparative perspective, mostly on Europe, but I'm trying to expand it to a more global perspective. I adopt causal inference methods to do policy evaluations, typically to look also for the welfare effects of policies that go beyond the intended effects of policies. For example, a pension reform that might impact also the health of individuals, not just their employment decisions. I also study social determinants of mental health and the measurements of living standards. So today, the presentation is about long-term care. I thought I would start from a slightly more broader perspective on healthy aging, which is a process that from this graph, this diagram, I just want to make clear that from my perspective, an analysis on aging needs to take into account, especially by economists who tend to be a little bit one-sided, that there are many dimensions that go on together within the aging process. So there is an aging component that involves changes in the autonomy, physical conditions, the well-being of individuals. On the other hand, older people rely onto family and friends to receive care. They also have income and wealth decisions with which they can compensate family and friends, with which they can buy formal care. In all this, there is a role for the state. And this is where I focus more on the welfare state, the role of the welfare state, and in particular public long-term care into this. Long-term care, most of you know better than me probably but let me give not a definition, but an attempt to some core issues. So assistance for persons with reduced functional or cognitive ability. This reduced is the issue of my presentation. What does it mean, reduced, basically? But in general, we can agree, I think, on the general definition. It is estimated that 50% of people aged 65 plus will need it in the OECD countries. 16% will face catastrophic costs that can then translate into, of course, important intergeneration consequences. Of course, above and beyond the consequences for the person and their partners. We know about social, economic, and demographic changes that are putting pressures on long-term care, which makes it very policy relevant and socially relevant. the public expenditure on long-term care is going to double, so also economically from the budget point of view of governments. With tightening budgets, it's of course an issue. We know that part of formal care, a large part, is provided informally. I'm not going to focus on that directly today, but we know informal care is prevalent, highly valuable in the system, as I showed in the previous diagram. The OECD warns us. Countries differ in what constitutes long-term care and what are its objectives. The countries don't agree on what long-term care is or should be. So we have a general definition, but it's very difficult to say what should a standard long-term care package or system be. And also, we do not really know the consequences of such differences in country systems, let's say, the consequences of these differences in terms of the provision, in terms of the effect on access to care, effectiveness of care provided, quality of care provided. Part of my presentation tries to address these challenges. I apologize for my voice, and I've not been very well in the last days, so I'm a little bit weak, but I hope that you can understand what I say. Healthy aging, we are in the decade of healthy aging, so let's look at this nice reminder from the Decade of Healthy Aging project. Healthy aging means change how we think about aging, ensure that communities foster the abilities of older people, deliver person-centered integrated care. But look at the fourth point, provide access to long-term care for older people who need it. This is very good, very nice when you say it, and then you need to translate into a legislation or into some rule. And that's where the problem starts, not the problem, but the challenges start. So this talk, I'm going to cover two main focuses. I'm first going to discuss my knowledge and my review together with other people on the definition of long-term care eligibility rules, so basically what is need of care according to government, the implication that this has for potential coverage, and then the outcomes of long-term care systems as they are affected by these rules, access to care, well-being of people, and I'll just have, if I have time, just a small mention of the cross-policy effect that I think is relevant. So, definition of needs and systems potential coverage. Again, a general description of long-term care systems. How should we define long-term care systems? There are many ways. This graph is the proportion of people aged 65 plus that receive home care or institutional care. I like this graph just because it shows us how different countries are. Is this because people have different needs? It could be. It could also be that people have different kind of access to public home care. Perhaps those countries on the left, perhaps they have just a higher bar in the invisible source, which is family. Family is not there. So it's possible that they are all equal, but the composition is different. However, we are interested in public form, and so this is still relevant. Home care use versus institutional care. I'll say about the difference. I'll say something about the difference between them in a second. Another stylized fact, countries also spend very differently on long-term care. This is public expenditure on long-term care that can come into different definition, health or social. That's quite complex. OECD warns us about the comparability of expenditure data because long-term care can come through the health department, but also through the social department. But in some countries, there is no difference. I can also tell you that above and beyond this problem, there are other problems in this graph. For example, and I know this for Italy. So I know I asked the OECD and they told me, yeah, this is a real problem. So you can see Italy here spends very little, 0.6%. But this is not the actual expenditure of long-term care in Italy. It's much higher. There is a program of long-term care called Indennità di Accompagnamento, which is a national cash benefit on long-term care, which is not included here because it comes through a different, let's say, source. So it's ignored, but that would bring Italy up by 1%, which plus 1, I mean, or at least plus 0.6, 0.7. Anyway, much higher than that. So Italy would be much higher in this range. So let's be careful with this kind of classifications. My focus of this presentation will be on home care. Home care is increasing in all OECD countries. The proportion of people aging in place is increasing, and this makes it very relevant for us. So, to the core of my argument, access to public long-term care is not automatic. It is mostly regulated by law. And this has been discussed by many studies in the last decade, also in the previous decade, but clearly this has taken a larger part of the literature's interest in the last decade. So we typically, and in economics, we typically assume that need of care is an important driver of long-term care demand, rather than aging, need of care. So what is need? Well, for the person, from the perspective of the person, it could be whatever the person thinks it's a need. And we typically, from the outside, assume, okay, if someone has one or more difficulties in activities of daily living, they have a need, for example, no? But actually, when you then want to receive some help that can come into an in-kind benefit or an in-cash benefit, then what matters is what the government believes a need is. And so the need of care in the long-term care legislation could be very different than what scholars believe that is need. So in actual legislations, there are assessment of need and eligibility rules that define whether someone is objectively, so-called objectively, from the legislation point of view, in need of support. And there is no unique clinical definition for need of care in the clinical literature. There are many concepts of frailty, disability, multimorbidity, several concepts of loss of autonomy also. We couldn't expect that with the lack of unique definition from the clinical side, we would have a unique definition in the policy side. And indeed, we don't. And my work tries to show this. Basically, if you look at this diagram, what we try to focus is on the left side. Long-term care coverage, not just how much and what, but who should receive care, who should be entitled to receive something. What are basic needs? In this diagram, again, from the decade of healthy aging, you can see learn, grow, and make decisions, be able to be mobile, build and maintain relationship, contribute. This is one perspective. Also, I like this diagram that shows how the functional ability that you can see with the black line can be supported in a way by several environments, the health system, the long-term care system, and other environments. Basically, what I try to study is how the differences in which we design long-term care systems can support people's maintainment of functional ability over the life course in older age. So, and I'm going to focus on this, assessment of needs and eligibility rules. These are the tools that the governments use to identify those who are in a condition of objective vulnerability. How is this defined? What consequences does it have? Vulnerability is undesirable, but it is not directly observable. And there is an ongoing research that I'm doing also with Mauricio here. We are trying to do a critical review and then applied analysis on long-term care legislation. There are first results that are published in the book that is below the video. Sorry, this should move so you'll see the cover. I didn't choose the cover. There is a new work that is being done together with other projects, the Gateway to Global Aging, which is a wonderful resource for scholars on long-term care. They try to build homogeneous microdata over the world for scholars to analyze long-term care and other social policies. The OECD Health Division collaborates with us and the WHO Kobe Center for Health Development. So in our review in general, we have seen that all these, at least, let's say, this is a very broad list of conditions that enter at least in one rule that we reviewed. I'll tell you what kind of rules we reviewed in a second. So we go from ideals to IADLs and to other limitations. And this is a general list. The problem is that when you then look at specific legislations, in some legislation you could find just 5. You could find just 5 of them. In other legislations, you might find all of them. And this is not the only difference. For example, in the Belgian APA, we have just a few outcomes as criteria, but in Flanders, the Flemish region, or in Germany, we have dozens. This is a partial list of the rules that we have reviewed in Europe, in the Italian regions. Italy is like Switzerland. The long-term care system is very decentralized. So what we have found is that mostly all rules consider ADLs. You can see it by seeing that the ADL column has a lot of checks. IADLs are also, I would say, commonly considered, even though there are rules that don't include IADLs. There are rules that include IADLs only partially. Almost all the rules consider cognitive impairment, for example, but for example, the role of mental illness is instead quite limited. Look at the column on informal support. What does it mean? This column captures whether the fact that an older person has access to informal care matters or not to the definition of need. And you can see that there is no check, at least on paper, and there is instead, for example, a check for these two Italian. Even going beyond this and looking at how the eligibility rules then are operationalized, so the eligibility threshold is defined, you can see they are it's very difficult to compare them. For example, in Austria, the eligibility threshold is measured in terms of hours of care per month. In other countries, it's measured in terms of points. How many points do you score out of the total? It's very difficult to compare them. So, different definitions of eligibility threshold. Another difference that you couldn't see in the previous slide is that even within a country legislation, different limitations could carry different weights. For example, in the Austrian Pflegegeld program, limitations in washing, in dressing, in using the toilet matter more in defining need than other IADLs. And the same is for cooking and house tasks among the IADLs. In Italy, for example, the Friuli Venezia Giulia region, where I live now, cognitive impairment is a sufficient condition to receive care. So we have a lot of non-linearities. There are rules that focus on ADL mostly. They target more severe conditions. There are rules that focus on IADL also. And this seems to suggest that they have a prevention attitude. They want to include pre-frailty state. They want to capture people earlier. As I said, there is limited role for depression in this. And there is a debate on whether we should or not include informal care availability into the criteria for defining need of care. There is a big debate on this because depending on what you choose, you may hurt vertical or horizontal equity. And I'm happy to discuss this. The result of this review leads us to realize that we can observe people with similar clinical profiles that have different eligibility status, either because they live under different legislations, because the legislation changed, or they live in different countries or regions, or because even though they look to us economists, you think, that have perhaps not a very nuanced perspective on need, they look similar in terms of their health, but their actual combination of limitation is different, and therefore different rules would treat them differently. This is an example from 4 profiles of people of similar age, 74 and 85, 74 and 84. They look like they have a similar profile. They all have difficulties in ADLs, difficulties in IADLs, some have cognitive limitations, some don't. However, 2 of them are eligible only in Belgium, and 2 of them are eligible only in Germany. What's the rationale for this? We don't think there is a strong rationale. It's just a lack of communication, but I think the OECD is also arguing we are going towards a larger debate on what needs are. So we should push for more homogeneity in these systems. Long-term care need means a different thing. Even across similar countries, you could imagine European countries, continental countries, how different might they be in defining needs? How different might the sensitivities be? Well, in order to answer this question, we use microdata from the SHARE survey, a European survey, panel survey that runs since 2004 and focus on individual age 50 plus. What we do using the SHARE survey, in the SHARE survey, we have for our respondents a lot of characteristics in terms of their health, their functional limitation, their cognitive limitation. So what we do, we basically compare their clinical profile that we have in SHARE with the legislations that we have collected. And we do this exercise. Okay, this person A that lives in Belgium, would this person, given her clinical profile, be eligible according to the definition that the Austrian government gives, the German government gives, the British government gives, blah, blah, blah. We try to do this kind of exercise. And what we come up with is an exercise, is a result that is called a direct adjustment analysis. So we take the shared population, basically, as if it were one country. And then we adopt to each of the individuals in SHARE a number of rules. And we check how many people would be eligible under rule number 1, under rule number 2, and so on. And this is the result. The height of the bar is the percentage of 65 people that we have in this survey that would be called as in need of care. So let's say they would be able to receive at least some help from the government in kind or in cash. Due to their loss of autonomy. And you can say that the percentage varies greatly between Poland and the new German rules. And this is the Italian national program, as we estimate it right now. Not just that, but countries that, let's say, even though countries might have similar eligibility coverage, they do not necessarily cover the same people. England, which was not in the previous graph, I'm sorry for this confusion, but if you compare people eligible to the English and to the French rules, you will see that many people are eligible to both, but there is still an important part of 65 plus population that is only eligible under the English rule or under the French rule. And similar, you can compare Flemish region, Flanders and the Italian Veneto. You can do many of these comparisons. So let's say the last thing, and I'm going to be very quick on this, the OECD also shows us that the way in which eligibility rules are defined, the way in which people are supported, matters a lot for the extent to which they can avoid facing catastrophic costs. And so the cost that they are going to face when they are at different level of needs might be very different across countries. I don't have time to focus on this, but I leave you the slide. So I'm going to have my glass of water. What are the limitations so far? We excluded countries where assessment is subjective or very fragmented. When a country like Switzerland, like Sweden, like Denmark, like the Netherlands somehow say, okay, we do a tailor-based assessment of need. We don't have a nationwide assessment rule, a nationwide eligibility grid. When at that point we stopped, let's say, we haven't been able to sort this out so far, let's say, for many countries. Another problem, we can only establish a weak link with intensity. We have only been able so far to understand whether someone is likely to be eligible or not. But the degree of intensity, for example, in Germany, it's true that Germany has a very high bar of coverage because in the new reform, they have lowered the minimum level of eligibility. So to people that have very, I don't know whether we can say low level of needs, but let's say lower level of needs than before, they give a small amount of, still an amount of money per month. let's say, no? That money could be considered small by some of us, but still they are eligible. No, so I'm ignoring this intensity problem. So this is a limitation that I need to overcome. I'm also excluding community-specific long-term care programs. And also, we know that some programs of long-term care do not actually monitor the way that you spend the money that you receive. So some long-term care programs are not targeted, let's say. Now you can spend the money however you want. For example, in Austria and in Italy, this is the case. So this could be also problematic for the analysis. So let's broaden the scope in three ways. First of all, can we show that these eligibility rules matter for access to care? What I've shown you so far is potential coverage, no? It's theoretical coverage. But what about actual access to care? So are eligible people more likely to access care? Does the policy matter? How do we answer this question? The first thing we could do is compare the rate of care use between people who are eligible and people who are not eligible. And we will find that people who are eligible use more care than people who are not eligible. And so what can we really conclude? Very little, because there is a big empirical problem. Sicker people are both more likely to be eligible and more likely to use care. So what we want to estimate is actually only the effect of eligibility above and beyond the effect of health. And in that, we, based on the literature that I contributed to as well, that basically by collecting these rules, realized that these rules are actually nonlinear indices. As I tried to show you before, they are a nonlinear aggregation of health conditions. This means that we can actually observe, because what we would like to do is the question in the third big bullet points. Can we compare the access to care for people that have similar health but different eligibility? Can we do this? Well, we argue we can, because the rules allow for this. Rules are nonlinear, meaning that within countries, similar individuals may face different eligibility due to specific combination of difficulties. That shouldn't matter much to them, but actually matters for the legislation. But there is also high heterogeneity across countries or region and also over time, meaning that very similar individuals, otherwise similar individuals, might have different eligibility because of the different legislation they are subject to. So what we try to do is this. We try to the intuition comes from this graph. We try to compare the probability of receiving care for people that have similar health, similar number of limitations, for example, in ADLs or in ADL plus ADL limitation. This graph shows you that the probability of using care for people who are eligible is always much higher than for people who are not eligible, even though you control for, in a very raw way, for their functional limitations. We also do it in a more formal way. And we estimate that basically the average effect of eligibility is a boost in the probability of receiving care by around 10 percentage points. We do it by estimating an equation that has formal care on the left-hand side and then the eligibility dummy on the right-hand side, and then a very large bunch of individual health characteristics that also determine eligibility, so that we want to make sure that the coefficient for the eligibility variable only captures the, let's say, the residual policy effect of the fact that someone is eligible. And we still find that eligibility matters a lot for access to care for people in Europe. There are also differences a little bit by characteristics. We are exploring this, but it's interesting that between people who are non-eligible and people who are eligible, for example, the probability of receiving care is always higher for people who are eligible. But for those with low education, the increase is lower. So potentially suggesting that there might be some issue of health literacy or access to ability, let's say, to navigate the complex system in some countries, perhaps. We still have to address this. Whereas there is little different by sex and also by wealth, actually, the picture is quite confused. So there is no clear indication. Policy-wise, this means that when policymakers realize that the way that they define the rules, they could also do some sort of simulation. This is a very simple simulation. What would happen to the proportion of people using care in each of these countries if we would change their long-term care rules in two ways? First, we make everyone with an ADL limitation covered by public programs, or two, the gray bar, we make everyone with at least one IADL covered by public programs. And you can see that the increase is not stratospheric. It's an increase in care use, which means that according to our estimates, that this could be an interesting exercise if we can link it to cost, also to perhaps simulate the potential cost and gains of changing long-term care rules. Third topic and second way of broadening this scope. Does it matter for individuals' well-being? And we answer, at least partially, one of the questions that OECD raises. Can we show that long-term care works, it is effective or not? This is a paper we are doing with Mauricio and Erika Reinhard. Does receiving long-term care through the public channel affect health, in this case, psychological well-being of older people in Europe? We argue this is important because of, and this is for home care, okay? So receiving home-based, publicly subsidized formal care. Does it help psychological well-being of people? We argue this is important because of the switch from institutional care to aging place to home care. We also argue it is important to answer this question because in economics, for example, the answer is yes by assumption, basically. The answer to this question is yes. In the economics modeling, receiving care is beneficial. It's beneficial to care. It's a positive component of the utility function because more care, in fact, affects health in a positive way, and that health affects utility. But the literature on this is more complex, and so we think it's important to give an answer to this question. Because, as I said, theories actually provide conflicting predictions. And also major depression is prevalent and costly, so we believe it's a relevant topic. Let me show you briefly what we do. In terms of outcomes, we use the same data I've shown you before. So the shared survey, 3 types of outcomes we have in this survey. The Euro D depression score, 12 questions that then are summarized into a score from 0 to 12, or a caseness index 0-1. A loneliness index that tries to capture whether people feel lack of companionship, being left out, isolated from others. This is also a binary, so not a score. And then a quality of life measure, so a more general measure of quality of life called the CAST 12. Perhaps you are very familiar with this. And in that case, we would argue what's the sense of control that people have over their lives, what's the sense of autonomy they have, their self-realization, and the pleasure that they have in their activities. So these are the 3 outcomes we evaluate. We face the same problem as we faced before. We need to make sure that we capture the effect of receiving care, the causal effect of receiving care, let's say. So in order to answer our question, we adopt an instrumental variable approach where we use eligibility rules as an instrument for receiving care. There is a big problem of endogeneity behind this question because you could argue depression and receiving care. If you, again, perform a naive analysis, a starting analysis, you will always find that people who receive more care are more depressed. But that's not because they receive, not necessarily because they receive more care. That's because they are sicker, they receive more care, and they are also more depressed. So in order to try to identify a causal element, we basically only look, let me put it very badly, at the effect on depression of people that were induced to use care because they were eligible to it. So compared to someone of similar health, but who is not eligible to it. So in a way, it's not a choice to use care because you are sicker. You use it because you can, because it is given to you in a way. No? So this is an instrumental variable approach, very similar to what I showed you before. What are the results? The results of this approach in the column 4 is that receiving any formal care reduces depression. So it is beneficial for depression. This is what we find in this study. If we would not account for this problem of causality, we would find the result in column 3, a positive coefficient, the higher it is, the worse it is. So more formal care, more depression. But if you control for causality, basically, in a way that you believe in, of course, you find an opposite result. A reduction in depression by 2.2 points in the Euro-D score, which is a large effect, according to the Cohen-D taxonomy, for people that receive formal home care through the channel of public eligibility system. There is also a reduction in the probability of being depressed by 12 percentage points, and the reduction in the risk of loneliness by 5.5 percentage points. So it looks like there is a realm of effects that combine together to improve people's feelings. And we show this also with the results on the CASP quality of life variable that shows that receiving formal care improves the sense of control and the average, let's say, probability of having a high quality of life, even though there is no threshold agreed in the literature for what should be a high quality of life. I just define it with being above the median level of quality of life in your sample. So if you receive formal care, it's likely that you are above the median level of quality of life. This is likely to make you, let's say, above the level of quality of life compared to the other people in the median level of quality of life compared to other people in your sample. So wrap up so far. Long-term care rules have a large impact on access to care. So they matter. Therefore, all the discussion on how to define them matters a lot. They can have important consequences on economic costs. They can have important consequences on people's well-being. However, we still need a better link, I think, between microdata and macrodata to exploit this variation in long-term care policy over time and across countries. Our microdata sometimes are too simple. The shared survey sometimes lacks the depth of detail to make a full comparison with the long-term care rules. And on the other hand, for many countries, we lack some information on rules. Yeah.
I'm just wondering what instruments they use besides the result.
Yeah, so the instrument is a dummy variable for being eligible or not to receive care in your area of living, controlling for health and for regional characteristics and so on.
I guess one worry could then be that kind of take in which regions, right, that then the broad eligibility threshold, and then you kind of, those will have more mental health just because they're kind of in a better off region with some stuff in the shared data.
Possibly, yeah. We control for this with fixed effects for regions.
Okay, so this is over time.
No, not necessarily. We can do it over time. It doesn't change much. It's weaker because we have less variation, but the direction is the same. But the fixed effect, meaning that each region has its own coefficient, so that. But perhaps we could try to add more characteristics, more region-specific characteristics, like the one that you suggested. I want to think about that. Yeah. Yes, please.
So a question on eligibility. Eligibility based on health and functioning.
Yes.
Are there all those criteria like income or means tested rules that allows you to access public service?
So in the countries that we use, income is basically never able to exclude someone to receive. Perhaps you receive a little bit less, but you are still eligible to it. Okay. We are trying to model this anyway. Yes. From the result that we see, it doesn't change But yeah, that's a very good point. Yes. Also, governments support informal caregivers through eligibility rules. They give cash to people, and this cash can be used to buy, to compensate informal caregivers. We also lack evidence, however, on the effectiveness, comparative effectiveness of informal care and formal care on health outcomes. So also this is something I think we need to improve in order to give better policy advice to government. I believe also we lack an historical and long-term perspective, a life course perspective. Can we isolate and identify the impact of different exposure to various policies over a life course? I'm basically assuming that what matters is the legislation that you are under now. But perhaps there is more to your past that I'm completely ignoring. And I think also other social policies, the exposure that someone has had over different kind of social policies over his life or her life might matter then for the effect that being eligible or not has in old age, access to care and on the outcomes. And this leads me to the last point that I'm just going to hint. We know generations' needs actually intertwine, but do social policies, this is a bit of a provocative question I tried to come up with, hints from a UK pension reform case. Just very briefly, we have a social policy that in theory has nothing to do with long-term care, pension reform. Because of aging societies, people have to work longer. No, so reforms that increase the state pension age, for example, in the UK. So if you look at an adult worker, this probably will impact her work, income, and wealth, might also impact their health. But we show with Mauricio that this also impacts her social activities and caregiving. She works longer, she reduces the care that she provides. To whom? To an older parent. So also the life of the older parent is affected in terms, for sure, of the care network, because the care network of this person, we show, shrinks. In our case, it is daughters who work longer, provide less care to their parents, and from the perspective of the parent receives less care. No one substitutes for the foregone care. It's not that there is a son that jumps in, or or another daughter, or the government, or the private sector. No, there is a shrinkage in the care network of the older person. So this is a new paper that we are finalizing. And the paper shows that also basically other policies that have nothing to do with long-term care, you would believe at least, should coordinate with long-term care policies, and the other way around. Long-term care policies should take into account other policies in order to basically avoid unintended impacts, unintended inequalities in care for older people. And I'm gonna stop here with this review. And welcome all your questions. Thank you very much.
Thank you very much, Ludovico, for this very rich overview of your work in program. So,
Thank you very much. That's very interesting. Just have a question on, you mentioned intention to use informal care to define needs, or this was your blank column.
Yes.
In which direction do you think this goes? Is it like it's a proxy for needs because you use informal care, or is it the fact that you have a substitute in fact, and so you need less formal care?
Exactly. That's the question. I don't have an answer. I know that there are legislations that say we want to be carer blind, so we don't even want to know. It doesn't matter. No, our colleague from the OECD says if you are myopia and you have glasses, it's not that you don't have your problem anymore. No, you still have your problem. In this case, with informal care, people with horizontal equity, people with same level of needs, physical needs, they should receive the same level of help. No, so in that case, carer blind. However, you could argue, but then practically you already have someone who helps. So perhaps it's more efficient that I give more money to someone who doesn't. No? So in that case, you would have vertical equity. These people are not actually similar. One has a support, the other one doesn't. So they should be treated differently. But in which direction? So many legislations do like this. Not many, some legislation. In the Netherlands, for example, it's written in the legislation, the public system, let's say, intervenes after the family has provided a reasonable amount of help. Let's say, in Italian region, there are a few regions where basically they say, if you don't have informal care, if you don't receive it, you won't receive help from us. So that's even a more extreme. You need to receive informal care. It's a message to the family, to the broader family. If you don't help the person you need, we won't support you. No? But then there is the other way around. There are other regions where the effect is negative. If you have informal care, we will give you less money. So it can go in both directions. It can be a way to incentivize informal care, but it can also be a way to say, okay, you already have something, I'll give you less support.
From the informal care, do you know, is there evidence if somebody as an informal care, does that put me in economic difficulties? Assistance from the government? Like, is there an impact on informal care?
Yes, so the literature is quite rich on this, so we can find a good question, a good answer for you. Not now, but let's say overall, there are studies that show that providing care might be detrimental for the health of the caregiver, mental health, physical health. It depends on the job that the caregiver does. If she or he has or not a job, perhaps she had to give up a job. It depends on the schedule. It depends on whether other people help you. But yes, there are consequences. So this is another important point. We tend to take for granted informal care, but it's important to ask whether it's a choice or it's mandatory, whether there is a norm over your head for which you are ashamed if you don't do it, but you wouldn't really like to do it because of many reasons that I don't want to judge. No? So it's really a thing, because then we start judging a little bit. No, you should do it. You should do it anyway. Or, so, good point.
Regions where they require some
Yes.
informal care.
Yes.
Does that have more detrimental impact on women? And so
That's a good point. I don't know. That's a good point. But I don't know. I think that
Can you remind us which proportion of all informal care is provided by women?
well, large. I think at least 60% in England, 65% probably in England only. Yeah, so it's large. It's also concentrated from caregivers that are at a given age, 50 plus. Mostly. That's a very good point. I don't have evidence on this. I don't think policymakers care at that point, but we can make them care. Now they just want, of course, to have not a substitute, a complement to formal care. Yes.
Yes, sir. For the caregiver, of course, I mean, I find it interesting that at some point you use the number of daughters to control for that. I mean, it's quite informative anyway. But although if I get your point, I hope I follow everything. The idea is to say that if you're more eligible, then you get more care, and if you get more care, you get better. That's the interesting.
That's a good point. Yeah.
That's the point we want to get to. The idea I was wondering is that you use the home-centered care, which is not very dependent on your relationship to institution, the society, social representation. I'm a social psychologist, so it's not seen as something positive when you go to a home. So I was wondering if you have a mean to know if the improvement in depression, in reduction of depression symptoms is pretty significant compared to the general population. That is, that you could have some not eligible person, they don't have access to help, to support, then they're really, really low. And then people that have access to home care, they're a little bit that higher, but not that high. So maybe there are other measures that could be better for the global health of those people.
So when I talk about home-based, I really mean the person's home, not the care home. Sorry. No, I am not clear. So not institutional care, not residential care, but home-based care. So person resides in her own place. Okay. This is what I'm talking about. So on institutions, things might be different. And I don't know, because to be accurate in the measures, which are already inaccurate, let's say, we restrict it to home care, because that's something we believe we have data on, because shared survey has information on people who live at home. When they move to institutions, they are followed, but let's say the history of share is stronger as of now for home people, for home-based services. So I'm focusing on home-based care. On your point of having a more broad, let's say, a broader definition, I think that's a good point. Perhaps we could have a discussion on this. You can tell me, where do you think that there could be gaps, or what could we be leaving out, let's say, or what could be the bias in a way? You know? But not now. I mean, no.
Maybe just to see if I can add to that on the question on the comparison to the general population. This population who receive home-based care, they are in much worse health and also worse mental health. So that's why the negative coefficient in the shown us on the right, on the left side. So they have worse health, right? So an improvement in their mental health may mean that their mental health declines less fast, or that there's an improvement, but by no means that means that they have a better mental health than the general population. That's unlikely to be the case. I don't remember the data, but they have much worse mental health, much more. Depression, for example.
Yeah, but I was thinking about politicians and the policies. I mean, they don't say increasement, and they say it's very significant compared to when you do nothing. I'm wondering, if it would be a stronger subject just to, improve the planning.
Like, what is more effective in promoting because I think your estimates don't really speak to that much, right? Because it depends on where you come from.
That's why I left.
Formal care.
Yes.
I was wondering, is there any evidence like showing informal care? So health outcome for the person.
I personally, I left this as a point here, because I think no, I'm not convinced. We'll say. I think that we lack evidence of the comparative effectiveness. I think I'm not ready to answer this. Very difficult to measure in a comparative way. So it's a very important point.
Just a question related to the informal care. Do you have any idea on what is the impact of informal care generally? I mean, especially in the future with fewer persons in young age, more people, more population.
Yeah, so informal care is a huge value. We have seen recently the estimates in the UK. If you would value an hour of informal care with the same basic rate of a nurse wage, let's say, nurse hour rate, the amount of value of informal care would match basically what the England spends for health services. So it would be huge. And this is in England. In other countries, it's even larger, sure. What you point out is important. Yes, there is an increasing pressure. There are estimates. I think that the London School of Economics, that the PSRU has done analysis that tries to answer your question in a more detailed way. I don't remember exactly the figures, but they show the rate of increase that we should observe in informal care provision in the future in order to keep the same level of coverage that we have now. It was an important increase. So informal care should increase in order to keep things as they are now, because of what you were saying, changes in demographics, also changes in societies. People work longer, for example, even just because they want to work longer. They have fewer children. So perhaps also people move more. So yes, I agree. That's one of the motivations for governments not to abandon long-term care from a public perspective, of course, because we tend to think, okay, the family pillar will always be there. But perhaps it's not a wish, it's something like it's an obligation, and then it becomes a potential problem. Because some of the things that you're saying are just natural, perhaps. So is there any other question?
Just maybe one very final, the share data is a bit more technical. I remember there was some social network data on where your relatives are and the distance and so on. Is that recorded every way, or was it just once? Did you know that?
So in wave 4, this was boosted. But I think there are problems in linking the exact identity of the person across waves. I've never used that with, let's say, in depth, because there were problems. I remember our colleagues in Venezia, they know a lot. We can put you in contact if you want. I know that they are being used, but there are problems. Depends on what you would like to do, let's say.
Can you use them, for example, to get some questions on informal support, or is that?
I think you can. Don't let me answer in a vague way. I'll think about it. I think there are problems in linking then the exact identity of this person across waves or with their characteristics. So, and yeah.
Okay, well, thank you very much. I think we can stop there. And,
Thank you very much.